have the privilege of having my neighbors down the street, not really down, like probably 15, 20 minutes away from me, presenting today from Chicago. And today we have Dr. Lin Frank Hill, who is a very good friend. We just met finally in the last AORTIC. I look forward to seeing you again in the next AORTIC and your team. And today we're going to be discussing infectious agents and cancer in West Africa. So Dr. Lin Frank Hill does not need introduction. She is the director of the Center for Global Oncology at the Institute for Global Health, and she has mentored a lot of trainees in Africa and even in the United States and beyond. And she's well funded, including NIH funding. So she's going to be talking to us today about infectious agents and cancer in West Africa. And she will be, of course, moderating her other colleagues that are going to be talking to us today. And just to mention their names, Dr. Mamoudou, Dr. Isaka Kamara, and Yaya Kasong Gay, and Dr. Niyam, and Dr. Deyemi Okonowo. So join me in welcoming Dr. Lin Fang, the Northwestern University team, who are going to be opening 2025 for us. Thank you. And you have the floor.
Thank you. Thank you for the good introduction. So Happy New Year and good morning or good afternoon, everyone. And so we changed the topic a little bit from focusing on genetic variants and cancer into infectious agent and cancers. I think this is more is a broader topic and not only covers what our team has been doing, but also I think can be interest to many of you. So I would like to tell us, you guys, that I'm not going to give a talk today, but to give the opportunity to our team members, in particular some juniors from Nigeria and Mali. So I have to thank AORTIC using this opportunity to support our research and team members. In fact, we have 2 trainees, big cat trainees, 3, and recently I have one who is raising her hand, IG, I can tell she may have a question. So our 2 mentees are funded by AORTIC AACR joint program. It's called Big Cat. And now recently I have a new mentee. We are also supporting other members to apply for the Big Cat to be supported for their research. So this is all I want to tell everyone. I hope that today's talks can, inspire you and to stimulate some very good discussions for us to learn from each other and see what we can do, in the coming year together. So our first speaker will be Dr. Mamadou Mega. He is actually not junior. He's well established in global oncology and also in infectious disease microbiome. He's Mamadou, I will let you to take over to do the first presentation.
Okay, thank you, Lifang. Thanks everyone for joining and for AORTIC for the invitation. I'm trying to share my screen. I hope you can see my screen.
Yeah, we can see it. Yeah, clearly.
Okay. Okay, great. So what I want to talk about today is our capacity building and training building in West Africa on infection-associated cancer. So you know me already. So I'm Associate Professor of Preventive Medicine at Northwestern University. I also have an adjunct position at USTTV, University of Bamako in Mali, as Professor of Microbiology. I just want to mention that my research focus, just for you to know me a little bit, is on 4 big areas. So one of them is the training and capacity building, which I'm going to focus on in this talk. I'm particularly also interested in infectious associated cancer on the contribution of tuberculosis in lung cancer in West Africa. I also work on the role of microbiome in different cancer, including colon cancer, cervical cancer, oral and oropharyngeal cancer, and the lung cancer. In general, we are looking for microbial population that are involved in inflammation pathways that can lead to cancer. And as you know, inflammation is the cause or consequence of most or all or most, if we want to be cautious of most chronic diseases. So we use those results. We are not only studying the composition of microbiome, but we also studying functional pathways. I mentioned inflammation, so we can generate those data and use different tools to understand how your microbiome is involved. So we use, for example, those microbiome biomarker or epigenetic, which Lifang has done a lot as biomarkers to detect cancer diseases early, because in LMIC, the issue most of the time is that cancer diseases are detected at late stage where very few therapeutic options are available. So we focus mostly on prevention. So by doing so, we also develop tools. I am affiliated with the BME Biomedical Engineering Department. So we are really interested in developing those tools like point of care, all those tools that are adapted to the LMIC environment where there are a lot of dust, the temperature is high, electricity is not always available, and if it's available, it's not stable. So let's talk about the infection-associated cancer. Cancer in general, we know is going to be and is already a huge public health issue in low and middle income countries. That is just going to increase going forward, and that's something that should concern all of us. It used to be called a disease of the rich of the West, but it's no longer the case, as you know. And I can tell you, when we decided to create a center in Mali, the first question we had, why we do cancer? Do infectious disease? Cancer is not our problem. But those same people, 5 years later, when they understand the issue, are the biggest advocate for us to develop the cancer research in Mali. So the number are increased, as I mentioned. So we even don't have adapted tools that are affordable, easy to use, just adapted to the LMIC environment. And that is part of what we try to address. Infection-associated cancer is a big part of the increase in number, because in LMIC in Africa, for example, we have an overlap between infectious disease, which we already know are huge issues, but also, overlap with all the other comorbidities for chronic diseases that, not used to be the case in the past, like, people changing their lifestyle, people are having, for example, for oral and cancer are changing their sexual behavior with more oral and anal cancer than before. As a result, we have more HPV-associated oral cancer, for example, and people, more smoking, um, uh, more obesity, more pollution, more environmental changes, all those cofactors that explain those are all changing, are becoming, and as a result, the numbers are increasing. For lung cancer, just to give you an example, we know the smoking is the major risk factor. But in LMIC, we also have TB, tuberculosis, which we know is also contributing factor. So, so with Li Fang and others at Northwestern University, Kate and the leadership at the Institute for Global Health, we have been involved in creating a center in Mal. As I mentioned, it was not the research on cancer was very limited. So we had this goal to really increase the amount of research in this area, focusing on infection-associated cancer. Capacity and trade building meeting is the best way to develop the research and impact public health and policies locally. So we started from scratch, removing building and getting some material, sometimes even get used material from eBay, from our own pocket, just to start something. And we had to do that for 1 or 2 years to start, and then the first NIH grant was funded with LIFAM as the contact MPI. So now we have a functional center. I'm presenting now from that center, and we have a young investigator motivated. When we start, I told them that our first resource is not the building or the material. If we have people motivated, we can do everything. And I think time is confirming that. You can see here that the center the Center for Global Oncology has been very busy in West Africa, not only Mali. Nigeria is actually our main site, and you can see just mentioning the major projects, those funded by NIH and the IGH. So one advantage we have at Northwestern that we can have an idea. We go to for global health idea. We go to IGH. We can get a what we call catalyzer project, 25K to start a program or research on a specific topic, get preliminary data, and go for larger NIH funding. So we can count at least 10 so that are linked directly or indirectly to cancer diseases. So as a result of all those efforts, we can say the collaboration with Mali and Northwestern is almost 20 years. With Nigeria, more than that, I think it's around 25 years. But cancer research is more recent. And I think the last 10 years, that started with the last 10 years, but it has been very successful, and we have been recognized as by the White House in their moonshot program, and we have been mentioned there, as you can see here on their website. On training, as I mentioned, once we establish the first cancer center related program in Mali, so we were funded for a D43, and this was the first cancer D43 in Mali, and this is what we promised to NIS to accomplish. And we are at halfway, 2.5 years that we have been funded. We were able to develop the center first. That was the first goal. We used the money to train many young investigators. 8 master students are in training, 5 PhDs are also in training currently. I think 2 of the PhDs already defended their thesis. We established a new master program in molecular pathology in West Africa with students coming from Senegal and Burkina Faso. Mali is a French-speaking country for those who don't know. So we want to be a leader and an epicenter for especially francophones to train young investigators in cancer research, particularly in genetic and molecular pathology. So in this program has also include training for US young investigators who are interested in global health. So we have 2 seed awards from US and 2 from Mali. Nigeria actually is also a sub-awardee in this project because they had more experience in cancer research when we started this. And 5 grants resulted from, I saw you the list. After we did 43, we got at least 5 grants and then 12 publications so far. I don't know how much time I have, but I'm going to finish soon. So we also have another program on biomedical engineering, as I mentioned, to develop biomarkers. And that program was a model for us actually for the cancer one. This one is on HIV and TB, but it's resources that the cancer team is also using now to develop tools. To give an example, we have a smartphone microscope that will be used for tuberculosis smear microscopy, but can be used for breast cancer, for cervical cancer, pap smear, for example. Anywhere you need microscope can be used. So the 2 programs are working together to maximize outputs. This one has been also very successful, with at least 2 K43 funded from NIH. So that's all I have for you. Just to end here by acknowledging our team, those who have been involved in this program. So thank you. I will stop sharing.
Thank you, Mamadou. And Mamadou gave us an overview of what we are doing in Mali. Some of them are independent projects, some of them are in collaboration with Nigeria, because we started with Nigeria collaborators several years earlier from Mali. We basically extended our efforts to Mali, and now we even further extended to other Africa countries, and that will be in the future, and we can talk about it. So next speaker will be Dr. Yaya, who will give us his some information on his specific projects that Mamadou included in Mamadou's summary talk presentation. So Yaya, would you share the slides with us?
Hi, Mifang. I think I will pass the floor to Ishaka Kamara.
Well, okay, that's good.
Yes, thank you very much.
You are unmuted. Oh, okay.
Yeah, sure. Hello, everybody. As Yaya said, I'm working with Yaya on this project, and I'm gonna stop my video due to the network in Mali. The network capacity is really low in Mali, so I'm gonna just start sharing and then.
Yeah.
My name is Isiaka. So I am a pharmacist and I have a MPH in epidemiology. And currently I work with CREFPAM, which is a Northwestern University collaborator in Mali. So, and today.
Sorry, Ashaka, I thought it was Yaya who would be doing the presentation. Thank you
yeah,
very much.
No worries. Yeah, it's okay.
Yeah, thank you.
Yeah, sure. So today we're going to talk to you about one of our current projects we conducted in Mali in partnership with Northwestern University and and the NCI, the National Cancer Institute, which since it's a federal grant. So, well, and like I said, it's Arctic North America to present you this topic. So we're going to talk to you today about the Helicobacter pylori in the development of liver cancer sectional study. So we're going to follow with this methodology. From the background, we're going to give you the methods we used for this study, and which help us generate some data, and which we would summarize, and we'll let you know our future direction. So, as most of you know, the liver is a shaped cone and dark reddish, and the color is brown, dark reddish brown, and it's weighted about 3 pounds. And from the physiological standpoint, the liver helps to strengthen the metabolism. It helps detoxify foods or medicines intake, and also it helps in the production of bile, which helps in fight digestions. It stores vitamins and minerals, and it helps in production and regulation of hormones. It also helps in blood clotting, and finally, it produces nutrients. So what happens? The liver actually can be damaged, and this can be due to alcohol. It can also be due to like Hep C, Hep B viruses, and obesity also is another factor. Finally, there is in the peanut, there is aflatoxin, which is usually in peanuts, and steroid, anabolic steroids. All these really can damage our livers. These are really known based on really clinical data. We show you here actually the process of liver cancer development. So in your left, you see normal liver, which maybe, there will be like genetic changes, and there will be multiplication of cell multiplications, which actually, that's when cancer occurred. And so for H. pylori, which Helicobacter pylori, this is the type of bacteria that's known to colonize the stomach of more than half of the global population. And some recent data actually found that there might be a possible implication of H. pylori, namely virulent strains in hepatobiliary diseases. And, which can actually be present at all stages of liver diseases, till like with development of cancer to your right. And for that, H. pylori in Africa, there is actually highest prevalence in Africa, about 71%. And most of the strains actually found in Africa are KJ, Vake, Goyel, Fly, GGT to CTK. And also, like I was previously saying, there is actually, there were some isolation of liver samples of mama, and the presence of antibodies against H. pylori among cirrhosis patients. So from GlobalCon, we found that in Mali, there are 727 new cases of liver cancer in Mali. That was really in 2020. and the incidence of liver cancer was 5.15%. Additionally, like I previously said, when I was talking about study that have actually found that they might have like a correlation between H. pylori infection, liver cancer. So one of these studies here that was conducted in Ethiopia by Mekanon and colleagues, which found that H. pylori infection and HCC were actually, there is a link between them, but it was a single hospital study. So we decided actually to take that to the next level by filling the gap, by looking at to what extent and direction H. pylori may be linked to liver cancer. And like you see here globally, that was also in 2020, the incidence of liver cancer was about 900,000. And the mortality also was really high. So this study actually evaluated H. pylori infection association developing liver cancer, and it also determined the impacts of FB and FC in H. pylori infection in hepatocellular carcinoma, which is actually, there are other type of liver cancer, but the main one is HCC. That's why we really focus this research on HCC. So we use actually the following methods. So like we conduct a cross-sectional study, and participants were enrolled from 2 hospitals, and we perform clinical examination as well as laboratory tests. And we actually, for laboratory tests, we look at IgA and IgG tests for H. pylori trends. And as any clinical study, we obtained the University of Science, Technique and Technology of Bamako ethics committee approval to conduct the study. So to your right, you can see that, from H. pylori, we look at HCC, we look at also fibrosis levels, we recruited HCC patients, we recruited F1, F0 patients, F2 level patients, and we have also a control that we recruited from this study. And we included in our study HCC patients and fibrosis F0, F1, F2, and F4 patients who are 18 years and older, and cases diagnosed within past 2 years and reported in the 2 hospital cancer registry. The controls were patients with no HCC or fibrosis. And we excluded for this study extrahepatic malignancies patients as well as patients unable to give consent. We obtained the following result. So after conducted a descriptive statistics on demographic information such as age, education, sex between the 4 groups, we also evaluated statistical differences between groups of participants using SAS. This gives us the following results. You can see that the mean age was 48.5 for HCC patients, and 15% of it. We can also see that we got 15 of the patients were like female, HCC patients were female, as well as if you look at their weight too, you see that their weight were lower compared to other groups. For the IgA test we conducted, HPA positive for 55% HCC versus 20% control, and GROYEL positive for 35% HCC versus 15% controls. Finally, NAPE also were positive for 15% of HCC patients. But for that, the p-value was really more than 0.05. which, that one actually is difficult to. And we also conduct AIGG tests, but lately for that one, our p-value was less than 0.05. We got VACAE, which was 95% for control versus 50% for cases. And in the bottom, we see that in the middle, GROYEL positive for 80% control versus 40% of cases. Well, finally, we look at, like I was previously say, antigen HBS and HBC. So for the groups, you can see that 100% of fibrosis F0 and F1 were like F0, F1 and F3, F4 were like positive, while like 35% only were like positive for HBS antigen for if you go down to HBE, you will see it's 75% of ACC that were really positive. So in summary, we actually, since, you see that it's really a small sample size, and this study is ongoing, but for now, we actually generated this following result. The selling summary we got for this study is that VACAE and GGT may play a protective role in the development of liver cancer. And HPA, GROYEL, and NAPE are higher in HCC patients compared to control, although not significantly significant. So this study also got some weaknesses, which are actually small sample size. We need to extend it to confirm my hypothesis. And controls, clinical and socio-demographics information are missing. Like any clinical study, it's really sometimes difficult to keep patients, to really keep them to get all the information as you want, as fast as you can. It's really sometimes difficult. So which actually weaken a little bit our effort to summarize main clinical and socio-demographics characteristics. But again, since this is a preliminary data, once we are able to extend it to really show that our hypothesis is true, we'll be able to really get more of this information. So as for future direction, so recruitment is ongoing for strong preliminary data, and as you know, this is a cross-sectional study, which is really, from clinical research standpoint, it's really a weak study design. So it would be better, once we really get more data to really confirm our hypothesis, to move to like a case control study, which would be better to confirm that hypothesis. And I really can't finish without also showing you that for the human subject and public health significance stats, human subject research data was collected from individual undergoing screening, and USCTBRB committee approved it, and patients receive and review consent from detailed in study procedure, then to sign the form. Also, study participants benefit in receiving free cancer screening. Finally, inform policymakers for better, this study, we inform policy better for better communication, increasing public awareness about the importance of eradicating H. pylori to reduce the risk of HCC. That's really the public health significance of this study. And to conclude, I would like to really thank our partner from the NCI to Northwestern University, Harvard University, USCTB, and the CREFTAM team. Thank you.
Thank you, Ashaka. Because of the time, now we only have about 20 minutes left. I would like to make sure our other two speakers from Nigeria can have sufficient time to speak. We'll just keep going with the presentations, and then in the end, we'll give everyone opportunity to ask questions. So next is Yami or Nyam?
Yeah, I'm here.
Nyam, please go ahead.
Okay, so thank you very much, Lifan. I'll off my camera so that I can get stable network. Thank you very much, Lifan. Thank you everyone for joining. Let me share my screen now. I may need to send requests to be able to share my screen, so I just send the request now. Okay.
Okay, I think, yeah, okay, great.
Okay.
Go ahead.
All right. Thank you very much once again. So I'm Yam Jacob. I'll be presenting part of the work that I did at UIC on the distribution of human papillomavirus genotypes in HIV positive and HIV negative women with cervical cancer using a next generation based approach. So I will just talk about the brief background, which because of our time, I won't go through all this. But this is the outline. We have the purpose, significance, the methods, results, and we conclude. So cervical cancer is the fourth common cancer in women globally. We know that about 660,000 new cases was reported in 2022, and out of that, 350,000 deaths occurred that year. And 90% of all those cases occurred in low, middle, and income countries, which is a huge burden for us in low, middle income countries. It has been proven that 95% of cervical cancer has been attributed to persistent high-risk HPV infection, and this is vaccine preventable. However, in Nigeria, cervical cancer is the second most prevalent cancer among women. In 2020, about 12,000 cases were diagnosed, and about 8,000 deaths occurred. This burden in Nigeria is due to an increased rate of HIV accusation, and the younger women accusation of oncogenic HPV virus, in addition to limited access to public health and services and treatment in Nigeria. We know that it's important to note that Nigeria ranks fourth in the world in terms of HIV burden. So this is a global prevalence of HIV. Studies have established that about 14 high-risk HPV genotypes are linked to cervical cancer formation. And out of those, HPV 16 and 18 have been shown to be attributed to 70% of all those cancers worldwide. And if you look at the map here, you will see that Africa has the highest burden of HPV virus, about 22.9%, and Nigeria is in the red there. I won't take much time to talk about the history because of our time, but that's the natural history. We know that HPV, one of the commonest things that happen by the virus is that it normally infects the basal cell lining of the stratified squamous epithelial lining of the cervix. And once it establishes genome, it starts multiplying and then expresses this E6, E7 gene that goes to affect the RB gene and then the P54 and a lot of genetic activities that happen that leads to cancer. But fundamentally, this image here shows us that it's been shown that in the lifestyle and in the life cycle of women, about 80% of them gets infected with HPV virus because it's a sexually associated infection, but it gets cleared up by the immune system. So the ones that persist are the ones that progress to become cervical cancer. So if you see here, there are exposures like multiple sexual partners, early sexual debut, high parity, smoking, lack of, no circumcision are high risk factors that lead to HPV accusation. But once the HPV is acquired, there are factors that increase the susceptibility, and HIV is one of them. And we know that HIV reduces the immunity and allows those to progress. So, but if you see this diagram from here, HPV infected cervix, it takes up to 10 years to translate from HPV to progress from low grade to high grade squamous, but all this regresses back. 90% of them regresses back. It's just about 10% that progress to cervical cancer. HIV has been shown to be strongly associated with cervical cancer. In fact, it's one of the 8 defining cancers. And women living with HIV have a 6-fold increased risk of developing cervical cancer compared to women without HIV. And that's one of the burden that we have in Nigeria. And this is partly due to the reduced clearance, like I mentioned, that is the persistence that leads to that, and then the more rapid progression and lower chances of regression back to precancerous lesion. And it has higher rates of recurrence. However, it's not many studies that have directly compared the distribution of these high-risk HPV genotypes in HIV-positive women and negative women in Nigeria with cervical cancer. So we know the WHO strategy is to eliminate cervical cancer by 2030. And it has a 3 main strategy, is to have 90% of girls fully vaccinated with HPV vaccine by age 15, and 70% of women are screened with a high performance test. And that's where our basis is. And most of the WHO recommended screening now is HPV DNA test method as a screening method, a highly sensitive HPV DNA method testing for for cervical cancer screening. And then also 90% of them to get treatment. So we looked at the reports from Nigeria, and so far we found that the studies that have done HPV DNA detection in Nigeria, there's been a lot of inconsistencies in their findings, most especially regarding HPV 16 and 18, and particularly among women with HIV, women that are HIV positive. For example, there's a systemic review by Emerybe that looked at 18 epidemiological studies. The review included 18 epidemiological studies from 2009 up to 2019 and reported a prevalence of 20% with the most prevalent genotype as HPV 31, followed by HPV 35, and then HPV 16. And several other reports like that give varying range, prevalences and genotypes as the most prevalent ones. Another systemic review that we also look at and meta-analysis is recently done by Kabuga et al. He reported about 42 overall prevalence with 37% in HIV positive women, but the dominant genotypes are 16, 18, 31, 35, 52, 58, and 45. This inconsistency in reports, it is suggested due to sampling types, because different sampling techniques have been used to diagnose the virus. And then maybe it's due to sampling device, but ultimately there have been different HPV detection methods that are used. So we set out to use a highly sensitive method. But in a build-up to that, I just want to mention and thank Lifang for their support in JOS, because this is one of the things that inspired me to begin to look at that direction. It was when the genomic laboratory was established in JUF, supported by Lifang, funded by NIH, NCI, where we were looking at epigenetic biomarkers of HIV-associated cancer. And we got some equipments that are real-time PCR machines that could be used for DNA detection, but it has never been done in the region. So I did the first one, we did an oral cancer screening And in 2019, we got HPV 16, 33, and 35, and 52 as the commonest HPV that causes cancer. And we got that published. And then in 2020, I worked with Professor Jonah Musa on his K grant and looking at microbiome in northern region. And we did the HPV genotype using the Aniplex platform. We got an overall prevalence of 49.3%. And out of the 31 participants that had multiple high-risk HPV, found that 45.2% had 16 or 18, and then 12 had 35, and the other types had 41%. That helped us to establish and develop a standard operating procedures for subsequent HPV genotyping that have been carried out after then. And we co-authored 2 papers out of that. So that's me there. That's my boss, Professor Imade in the lab. These are all machines that have been supported by Lifang and the group in Northwestern and NCI. So because of all these inconsistencies that I just reported earlier, we thought we should look at the more highly sensitive, high throughput method of HPV detection, just to see if we can be able to identify the spectrum of HPV genotype that are circulating in our regions. And this may help in resolving the inconsistency in previous research, and also would help in developing more targeted and effective strategies of cervical cancer control.
Okay. Yeah, I want to give enough time for our last speaker, Yami.
Okay. So
thank you so much. And I want to add a little bit of what Nyam just said. This was done at UIC using a more complicated, expensive sequencing approach. But now we have set up HPV screening program at JOS. So it's more cheap, affordable, easy to use, very accurate, validated by NCI investigators. So actually we have really moved on to bring the technology to LMICs. Thank you. Yeah. Yami, are you ready for yours?
Thank you.
Yes, I am. Can I share my screen?
Sorry for giving you
no, it's okay.
Time that's less than.
I'll try to manage the time. Yeah.
Excellent.
Okay.
Yeah.
Let me share.
Yeah, yeah. Yes, very good. Go ahead.
Okay, all right. I think all right, so I know I have a limited time, but I'll try and make due justice to the little time I have. So I just want to talk about the project my team did in the College of Medicine, University of Lagos University Teaching Hospital. The title is on the prevalence and distribution pattern of cervical high-risk human papillomavirus genotype infections among women with high-grade pre-invasive and invasive cervical cancer in Lagos, Nigeria. All right, well, I have no conflict of interest, but just to note that the grant for this study was provided by the U54 project that studied the epigenomic biomarker for HIV and cervical cancers between 2028 and 2022. I won't spend much time on this. My predecessor has spoken about that. But it's good to know that cervical cancer is the commonest genital tract malignancy in this part of the world, and HPV, especially high-risk HPV, is known to be a necessary cause of it. And that's the basis of the HPV screening and vaccination to prevent and eliminate cervical cancer as much as possible. Right. The objective for this study were, one, to identify the high-risk human papillomavirus genotypes associated with pre-invasive cervical lesions and invasive cervical cancer among Nigerian women. And second, to also determine the genotype-specific prevalence of these high-risk HPVs among these women in Lagos, and to determine the prevalence and pattern of multiple high-risk human papillomavirus infection among this study. It was an analytic questionnaire study. It was conducted at the Lagos University Teaching Hospital in Nigeria. And it was also conducted as a part of the bigger study, the Nigerian first study, the Project 2, which was on cervical cancer. The study populations was women histologically confirmed high-grade pre-invasive cervical lesion and invasive cervical cancer, irrespective of the HIV status, and also they also were also meant to be part of the larger youth resource study. So it was people in the youth resource study that were recruited for this project. So data was collected using from the red cap of the larger study. This patient was saying cervical tissues were obtained from cervical cancer and CIN2 plus patients, and DNA extractions were done in the laboratory. And following DNA extractions was done and stored in the laboratory, and I had access to some of this DNA. And then we did using the Aniplex 2 HPV detection kits, all right, to try and detect the 14 high-risk HPV genotypes as listed on your screen. Thereafter, we're able to detect, try and determine the genotype-specific prevalence from our results and then the pattern of infection that were found. So what are the results? From the study, we had about 90 women were part of that study. 80% had cervical cancer, while 20% had CIN2 and CIN3. These are the baseline variables for the study of data of the study. Mean age was 54 years of age, and then their parity total deliveries, median was about 4, and other parameters also as you see on your screen because of time. Also, these are some of the categorical variables that we observed. Majority were married, but just about 25%, 26% were HIV positive, and majority presented with late-stage cervical cancer. And the commonest histopathology histotype was squamous cell carcinoma. Now, what we observed, we noticed that the prevalence of high-risk human papillomavirus in the study group was 91%. About 8 out of the 90 had no HPV detected from the 14 high-risk HPV group. We also observed that 55.6% had single high-risk HPV infection, whereas 35.6% had multiple high-risk HPV infection. And the pattern of multiple high-risk HPV infections were as you see, about 18%. The total multiple high-risk multiple infection were 32 out of the 90. 6 out of them accounting for 18.6% of the multiple high-risk infections, whereas we had dual infection in 78% of the multiple high-risk infection, while cortical infection was observed in just 1, accounting for 3.1%. This shows the high-risk genotype specific prevalence that we observed during our study. The commonest human papillomavirus cervical infection associated with invasive cervical cancer and CIN2+ was HPV 16, accounting for about 50% of the overall infection that we observed, followed by HPV 18 and then HPV 35 and 51. All right, HPV 39 was no infection with HPV 39 was detected, whereas HPV 31 only had 1 infection out of all the 90 women that we assessed. Comparing the, we know that we have a HPV vaccine, that targets the common HPV causing cervical cancer. We compare the 7 high-risk HPV vaccine that is infection that has vaccine targeting them, comparing to our findings, and we notice that 16 and 18 as seen worldwide had very high prevalence, whereas the other type of human papillomavirus infections that has HPV vaccine targeting them were relatively low in our environment, compared to 35 and 51 that has no HPV vaccine targeting it. Also, we also in trying to find out, the risk factors for multiple iris infection using the human papillomavirus infection. HPV 16 and 18 were seen to be significantly associated with multiple iris human papillomavirus infection in this patient with cervical cancer and iris CIN+, with 16 having 4-fold and 18 having 3-fold increased odds of having presence of multiple iris infection in our environment. So, in summary, our study, we found that iris human papilloma virus 16 and 18 remain the leading cause of CIN2 and invasive cervical cancer in our environment, similar to what has been reported worldwide. However, also iris HPV 16 and 18 was significantly associated with multiple iris infection in our environment. The prevalence of a 31 and 33 human papillomavirus subtypes were relatively low in our study, whereas the prevalence of 35 and 51, which was relatively high. However, these are not covered by the current vaccine that we have. The major limitation for our study was the small sample size that we had. We only used 90 out of the 100 plus samples that we had, and that was due to the limitation of funds for the project. So in conclusion, 16 human papillomavirus 16 and 18 remains a major cause of CIN2 and invasive cervical cancer worldwide and also in our environment. However, more attention needs to be given to iris human papillomavirus 35 and also 51 as an important cause of CIN2 plus and invasive cancer in Lagos, Nigeria. And further studies will be needed to confirm this. Thank you very much. I hope I spent the time judiciously.
Thank you, Yami. Thank you for all our speakers. I think in terms of time, I think we are doing okay. Good. Is that okay?
Yes.
We have some questions for.
Yeah, absolutely. Thank you so much for this presentation. This is very, very good. This actually is what we've been talking about, where we want to show collaboration and partnership within the continent and even with our North American partners to see who is doing what and, to learn. So it's already past 4 minutes past the hour. And I know that this is our first series. The next series is going to be coming up same time, first Tuesdays of every month. I implore all of us to join, and not just join because we are working with an institution and just not join again, because we actually learn. And the fact that infectious disease and cancer, it's very, very important because we have 15, even more than that, % of cancer cases on the continent is caused by infectious disease. So it's important for us to start thinking about this as a group about addressing this. The first talk that was given by the AMPATH team, they talked about malaria vaccination and the etiology with cancer. So we see from having parasitic infection like malaria to what Northwestern team just talked about, the viral causes or even HPV. And I just wonder, this is a question I thought, whereby I know that the report by Dr. Camara was talking about H. pylori infection and HCC, even though it was not significantly positive. I just think about the synergistic effect of H. pylori and hepatitis. Does it even increase the causes of liver cancer? And I'm also thinking about this will be interesting point where our AORTIC research committee can actually tap in and start working with our North American team. And we start thinking about how do we work in group. For example, the last two talks that was given, we're talking about the challenges as far as getting ethical approval in one country, especially if you're working in multi countries. This might just be the platform where we start thinking about, maybe we start thinking about regional ethical approval or regional stuff, especially since we'll be doing clinical trials across the continent. So I'm also hoping that this will be a place whereby interest group can actually start coming together first Tuesdays every month to see how do we collaborate, how do we partner, and how do we move the needle forward in actually addressing the incidents and prevalence and the morbidity of cancer on the continent. So I'm going to stop now and see if there's any question from the group, because I know that normally a lot of people start asking questions around this, and at the same time, I just want to be respectful of everybody's time. So thank you again, Lin Fang, for the questions, and anyone that has questions, you can actually email them directly. And just a little bit of housekeeping rule. Next month, first Tuesdays every month, please join us. And for the team Northwestern that came in to join, please join us next month. And we hope that you keep on joining. And the next time we meet in person is going to be hopefully in ASCO, and then the next time, which is the grand meeting, is in Tunisia. And by next month, we'll start sharing information as far as flights and all those things. So if you're like me that likes to buy my ticket upfront, I think it opens like 9 to 8 months before time. Okay, so I would defer if there's any questions or comments from anyone. I don't see anybody raising up. And we'll be closing the meeting and thanking everybody again for their time, and see you next month.
Thank you very much. Bye-bye.
Thank you.
Thank you.
Bye-bye.
everyone.
Thank you. Bye-bye.
Thank you.
Thanks. Bye.
Bye. Happy New Year.
Thank
Happy
you.
New Year, ma'am.
Thank you. Bye-bye. Thank you.
Bye.
Bye-bye.